Good morning, everybody. It's Lizzie Barrett here, the nurse educator at Nepean Intensive Care Unit. I'm talking to you today about intercostal catheters in intensive care. So this talk is designed for staff working in the Nepean Intensive Care Unit. However, if you are watching from another site, just be really mindful that you'll have your own local policies and procedures that you need to adhere to when dealing with intercostal catheters and chest drains. And practice may vary marginally from site to site, and equipment will vary from site to site. In addition, if your normal work environment is in a ward environment, there might be some slight changes in practice. So just be aware of those. So I apologise if you can hear the rain in the background. It's absolutely pouring here, so hopefully that won't disturb us too much today. So today we're going to go through anatomy and physiology. We're going to look at common pleural conditions for which an ICC might be required. We're going to talk about the indications and contraindications for ICCs. We're going to talk about the complications, and then we're going to talk about the nursing management and observations. Why are ICCs so important? Why is it important that we raise awareness about these devices and we talk about it? Well, I guess when we think about medical devices, and particularly lines, tubes, cannulas, and things that we insert in patients in a clinical environment, in a hospital environment, they all come with various degrees of risk. An ICC is a device that carries quite a significant amount of risk, because in the event that it is kinked, clamped, disconnected, elevated, things like that, things that seem quite, I guess, easy and simple complications, like things that can easily happen, there's potential for very serious outcomes, including death for the patient. So we are talking about breathing. So, if we're thinking about our ABC, we're talking about breathing. And chest drains, and the lack of patency of a chest drain, or a chest drain that's not in the right place, can really have a direct impact on our patient's breathing ability. In addition, they carry obviously an infection risk, and they also carry a bleeding and a PE risk. So, big risks when we're talking about it. So it's really important that we understand, I guess, the significance of it, of the catheter itself, that we understand the drainage system. And as nurses, we're monitoring and observing for anything that is abnormal with these devices, so that we can pick up issues early to prevent a patient deteriorating to the point of a significant decline or a cardiac arrest and ultimately death. This is really kind of dirty data, if you want to talk about it like that, not clean at all, but just a really quick snapshot to, I guess, set the scene and give you an example of how big a population we get with chest drains in the Nepean ICU. 2020, we had roughly about 1,800 admissions, and approximately 140 patients had ICCs. Most of those ICCs were inserted elsewhere, but they were all cared for within our unit. We had 3 reported issues or incidents on IMS, and 2 out of 3 of those were related to inappropriate clamping. So let's go back to basics. So anatomy and physiology. We have a really beautiful diagram here, and a picture always tells 1,000 words. So I'm just going to, I guess, pull out the really key bits that's relevant to what we're going to talk through on the subsequent slides. But you have your right and left lung here. They're really nice and fully inflated. Around the outside of the lung, you have, adherent to the lung, you have the visceral pleura, and that attaches to the lung, and it's like a thin sheet of tissue, and it's a continuous sheet. So it goes around here on the outside of the lung. And then at this point at the hilum, it turns into the parietal pleura. And the gap between those 2 layers of pleura is what we refer to as the pleural space or the pleural cavity. It is normal to have some pleural fluid that flows through this cavity. And obviously the size of this cavity changes depending on inspiration or expiration, whether the lungs are inflated or deflated. So again, I'll just point out here on this quite simple image, but again, easy to understand. You've got these 2 nice, really maximally inflated lungs. So when we run into issues is when we have lungs that look like this. So you can see this is again, a very simple image, but if you imagine the patient's at the peak of inspiration, so their lung should be nice and fully inflated, and this right lung is, but this left lung is actually quite collapsed. You can see here we still have the pleura on the outside, but we've got all this space here. And when we see this, so generally this space is going to be filled, well, always it's going to be filled with either air, fluid, so an excess of pleural fluid, or blood. And you can see it as this space fills more and more, so the space, the pleural cavity, or the space between the parietal and the visceral pleura, as this fills more and more with air, fluid, or blood, it's just going to continue squashing the lung down. So the patient's still breathing in and out, but this lung can't actually expand. And to be honest, you do get to a point where the pressure inside the pleural cavity means the lung can't expand at all, and ultimately impacts and applies pressure against the heart as well. So you originally start off with breathing issues, oxygenation issues, and can end up with hemodynamic issues as well. So instability in blood pressure, hypotension, because the heart can't actually fill because it's being physically squashed. So this is where an intercostal catheter comes in. We want to put a drain into this pleural cavity so that we can drain out whatever it is that's accumulating there. It might be a hemothorax, so blood. It could be a pneumothorax, which is air, or it could be an excess of pleural fluid in the case of a pleural effusion. And I guess that then takes us through to our pleural conditions. So these are the pleural conditions that you can have. So pleuritis, a pleural effusion, a pneumothorax, a tension pneumothorax, or a hemothorax. And these are the ones that we would insert a drain for. Now, depending on what the patient has will determine what type of actual catheter gets inserted into the patient, and the technique that the medical officers use to insert that drain. So there are small catheters, there are big catheters, there's a Seldinger technique. So when I say Seldinger, that's the process of using a hollow needle, popping a guide wire through, taking the needle off, and then putting the drain or the catheter over the top of guide wire. Or there's an open technique where you do a blunt dissection down into that pleural cavity using your finger to identify, I guess, the anatomy and where the tube's going, and then you place the tube. So I'll give you an example. A pneumothorax, you'd usually use a Seldinger technique with a small gauge catheter. For something like a hemothorax, you would generally use a very large bore catheter, because we need to allow blood and clots to drain out of that space. And that's usually done using an open technique or a blunt dissection technique. So contraindications, there aren't many. And the reality is, if a patient needs a chest tube, they need a chest tube. Conditions that require a patient to need a chest tube are life-threatening if they're left for periods of time without treatment. And so hence the reason why you have very few contraindications. And the primary one is probably this top one. So the need for emergency sternotomy or thoracotomy. If the patient needs their chest open, inserting an ICC is just going to delay time to that definitive or that I guess more invasive treatment. And for patients who are that sick, we don't want to be delaying that time. Pleural adhesions at the site of insertion. This is what this really nice photo of. It's probably not an absolute contraindication these days. You know, there's options to potentially use different sites. Like ultrasounds have given us, I guess, better imaging, and we're able to place chest drains in different locations more safely because we can use ultrasounds. But if a patient has lots and lots and lots and lots of adhesions, it may mean that they can't actually have a chest drain. So that would be something that you would be discussing with your very senior thoracic medical officers or intensivists in terms of how we're then going to manage that patient. And I guess relative contraindications, coagulopathy. So we want to ensure that our patients don't have any significant coagulopathy, and if they do, we're going to reverse them whilst we're putting in this invasive drain. All right, so I guess the biggest complications that patients have before, during, mainly during and after chest drain insertion. So pain is probably one of the biggest ones that us as nurses need to assess, be aware of, and very proactively treat. Chest drains can be very, very painful. There's lots of nerves that run around the area of insertion, and so it is important that we're very proactively treating that. Patients can have quite significant pain and pain syndromes for very long periods of time after a chest drain has been removed. So that's also something to keep in mind. And it can be nerve pain as well as, I guess, physical site pain. So it might be worth getting your pain team involved if the pain seems excessive or isn't being well controlled by the levels of analgesia that we have the patients on. Bleeding is an obvious one. We're doing this is a surgical procedure, so we are at risk of bleeding, infection, subcutaneous emphysema. So air may track either via the tube or via the incision site itself into the pleural cavity, out of that pleural cavity and up the subcutaneous tissue, rather than coming out the drain. That can be an issue with the drain not being far in enough. So you've got one of the drainage holes, and I'm going to show you some drains in the next couple of slides. It could be one of the drainage holes hasn't actually gone quite into the pleural cavity. So you've got air coming through the drain, coming out one of the holes up into the subcutaneous tissue. It could be that the drain has actually is malpositioned, so it's not in the right spot. It could be that the incision site is really large and you've got a much smaller drain in it, so air is tracking around the outside of the tube itself and up into the subcutaneous tissues. So really be aware of subcutaneous emphysema. You do need to be assessing it, and often if the subcutaneous emphysema is excessive and particularly extending into airway regions, so up the neck and in the face, it's a really great idea to mark it out so you have a very objective measure as to whether it's getting better or worse, because that's something we would need to monitor very, very closely. Incorrect tube placement we've just discussed, and obviously tension, pneumothorax and pulmonary embolus are also side effects. So this slide is probably quite medical and not so relevant to us as nurses, but it is always good for us to be aware of the general insertion technique and catheter types. I mean, we're going to have to care for the catheter, and we also assist our medical colleagues when they're inserting these. So as I discussed before, you can use either a Seldinger or a blunt dissection technique. Ultrasound guidance is considered gold standard, and certainly in the PNICU, that would be the expected level of practice. The insertion site needs to be within the triangle of safety, and you can see that marked out here on this image. So that's what we refer to as the triangle of safety. And in the event of a pneumothorax, the other I guess accepted site for insertion is in the mid-clavicular line. And many of you would have seen small pigtails inserted in that anatomical location. And then we have small bore catheters and we have large bore ICCs. So I'm just going to stop sharing just for a second so you can see some different catheter types that I have here. So this is a small bore pigtail catheter. You can see it's curled, hence they're called a pigtail catheter. So that's quite small. That's I don't have it on here, but maybe an 8 French. So that's quite small. That would be quite commonly used for an accumulation of air, so a pneumothorax, sometimes a pleural effusion, although you do find, because the holes, let me hold that up and see if it will focus on it, the holes on it are quite small. So if your pleural fluid is thick, so if it's as a result of, say, if it's a malignant pleural effusion, so maybe cancer, you might find that you get some debris, some thickness to it, so that might not be big enough. And if they're occluding, the medical officers may choose to put in a larger bore ICC. I don't know if that's focusing. I'm trying to get to focus on that. You have straight small catheters. So this is a small catheter that you might put in, and that's just a straight one. Again, that would just be used for air. I don't think anything else. And then you have your larger bore catheters. So this is one of the smallest of the large bore catheters. I'm just going to take this introducer line out so you can actually see. So that's it there. It's probably, you know, if I hold my finger there, it gives you an idea of thickness. And again, it's got all these drainage holes in the end. And this one here is a 14 French. The next one I have here is a 24 French. And again, I'll just take that introducer out. So again, starting to get a bit thicker, and you can see those drainage holes in the end there. And you can see down the side here, you've got markings, centimetre markings, and it's really important during your assessment that you're aware of at what depth this is inserted into the patient's chest wall. So that would be one of the things when you're doing a physical assessment you would assess. And then if something happened to your drain, you would ensure that it's not migrated either in or out. And then finally, I've got here a 32 French, which as you can see, it's a big bopper. This one would be used for a hemothorax. So if we needed to drain, so we've got a traumatic injury, we've got blood happening, we need to get blood and clots out of the patient. So you can see very large drainage holes. And if you were to compare these two, you're like, blood's never going to come out those holes, blood and clots. It's not even worth even putting that in if blood is our issue. We need something nice and big. Okay, so that's the drains themselves, or a variety, and they're not the only ones. It's just to give you an idea that there's a variety on the market. Some of the other kit that you might get exposed to, and again, this is site specific, and different places will have different ways of setting up their catheters and drains, but essentially we're going to put a catheter into the patient. Yep, we need to connect this tube, this catheter, in however it comes. So, you know, one of these catheters, we need to now connect this to a drainage system. So there's a few different things you can get. This is like a connecting tube. So for example, this might go on the end of so the doctors have inserted this pigtail into the patient. This might go on the end, and then this connects to your drainage system. Or your drainage system might just connect straight to the catheter that's been inserted. The other thing that you might see around are these. So this is like an anti-reflux valve, and you'll see on it, so it's designed for a chest drain. The flow can only go one way. So flow can come out, things can't go back into the drain, and that's really important. We don't want to put air or fluid back into the patient's pleural cavity. We want to drain it all out. These are great as long as they're inserted in the right way in the system. Just make sure that they're like the flow arrow. And I don't know if you can see that there on the side, but you've got a little flow. It shows you, the arrow shows you the flow of fluid or air. So you just need to make sure that that's being inserted in the appropriate way. So back to our presentation. In terms of the nurse's role during insertion, again, site-specific, refer to your local policies and procedures. The ACI have a great document out, which is where I've taken this information. It's reasonably generic, but there might be some differences from place to place. But you need to ensure basic resuscitation equipment is available. So in an intensive care unit, that's pretty straightforward. We have resuscitation equipment at the bedside that's specific to the patient. We usually have an intubation and a rest trolley somewhere in the vicinity nearby. It doesn't need to be brought into the patient's bed space, but as long as you're aware of where that equipment is and can easily access it. If you're in a procedure room somewhere, I guess that's where you need to ensure that you do have appropriate equipment nearby. The nurse's job is to set the underwater seal drain up as per the manufacturer's instructions. So whatever brand you're using, make sure that you do a check with the doctor that this is the right patient, right procedure, right site. And mostly in intensive care, our patients, actually, I'm going to take out the word mostly. Often in intensive care, our patients are not able to give informed consent because they're sedated, unconscious, delirious. So sometimes we're able to get consent from next of kin if that's reasonable. In some circumstances, this is going to be an emergency procedure, so you wouldn't need to get consent in that particular instance. We need to ensure that our patients have working IV access. If something goes wrong, we need to be able to administer drugs and fluid, potentially blood products. We need to have a look at their coagulation status. So are they, and I guess acknowledge their bleeding risk. Are they low, medium or high risk of bleeding? And do we need to give something to correct that coagulopathy before we start? We need to ensure that we're providing adequate pain relief and sedation if required. So if you've got a person who's ventilated, not particularly awake or alert and is likely to move throughout the procedure, then you would probably want to take the measure of sedating them adequately before you start, so they don't move at, crucial moments. You need to position the patient. So for most patients in the intensive care unit, we would do this procedure lying down. And the preferred position is head up 30 to 45 degrees, slightly rotated with the arm on the affected side lifted and placed behind the patient's head, so that we've got nice clear access to that triangle of safety. For lots of chest drains insertions, particularly for pneumothorax, they'll just do that I guess anteriorly, so on the patient's chest wall, so you won't need to position them like that. It's very rare in our environment that we would do insert a chest drain with a patient sitting up. They're usually not that stable. They're usually quite unwell. However, if you're in a respiratory ward doing this in a procedure room, that might be your preferred position. We need to help our medical officers to connect the drain, and we need to secure the connection of the catheter to the drain. And again, it's, your doctors may do this, but you just need to make sure that that job is allocated to someone and it's being done according to best practice. So the drain itself, I have a picture here of the drain that we use here at Nepean, but I do just want to say that products come and go. We use different brands year in, year out. So yes, it's important that you know your equipment, but for the purposes of this talk, don't get too caught up on the drain because the equipment does change. And I guess the overarching principles of a drain are the same, but different products will come with slightly different features. These days, they're all sterile unit, single patient use. I don't think I've really seen the reusable 3-bottle system for a very long time. I don't think they really exist in Australia anymore. I'm happy to be corrected on that. I'm pretty sure most sites would be using single-use disposable drains. There's usually a swivel floor unit, this bit down here, so you can stand it on the floor, and there's hooks on the side so you can hang it off the bed. The sterile water goes into the suction port and it's filled up to 2 centimetres. So there'll be a marking down here somewhere that says 2 centimetres, and that's how much you fill it up to. They can be used just on gravity, but mostly they're used with actual low wall suction applied to the drain. And I will just say that some drains don't actually they can use any suction, because the actual suction setting, like as in this drain, is you set the negative suction pressure on the drain itself, not the wall outlet, but that is drain specific. So yeah, you can see on this drain, you have a red dial where you change the amount of negative suction pressure you want applied through this drainage system. So you can use whether high wall or low wall suction. From a safety point of view, I always tell staff, please try and use a low wall suction outlet, because if for some reason this fails, that's your safety backup, essentially. You need to turn on the suction until the orange float appears in the window. And again, that's specific to this drain. So just make sure that you're, again, using the steps that are appropriate for the equipment that you have. We've talked about changing the suction, and there is a high negativity release valve on this particular drain. So if you're ever in the event where you see that your water level should be sitting at 2 centimetres of water, if you see that your water has been sucked right up to a really high centimetre level and is staying there, that's because you've got a whole heap of negative pressure built up in the system. We actually need to release that. So whether you do that by taking the suction off and popping it back on, or like I said, some drains will have an actual built-in release valve that you can press. All right, so nursing stuff, physical assessment. So your patient's got an ICC, you've just come on shift. It's really important, I guess, you know, you have to do a comprehensive physical assessment anyway, but this is the stuff that is specific to a patient with an ICC. You need to look at their respiratory status. So what is their baseline? And then you need to observe for any signs of respiratory distress. So that could be an increased work of breathing. It could be unequal chest rise and fall. It could be a decrease in saturations. It could be an increase in respiratory rate. It could be use of accessory muscles. It could be you know, an increase in subcutaneous emphysema. So all of those things you need to be observing for and measuring against your baseline physical assessment to assess whether things are changing or not. And obviously, if things are changing for the worse, you need to escalate your concerns to the medical officers. You need to look at your ventilation settings in the case that your patient is ventilated, and particularly the presence of a leak, and then the size of the leak. So most ventilators will have a way of measuring that. And the reason why that's important, because if a patient develops what's known as a bronchopleural fistula, leak through the ventilator will become really important. So that is, we've got air going into the lungs, and whatever we're putting in should really be coming out, but the ventilator is picking up that what's coming out isn't matching what's going in. So it's disappearing somewhere into the patient. So it will alarm and tell you you've got a big leak, what's happening to this air. And you can, if a patient has a bronchopleural fistula, you can see it in the drain. The drain bubbles furiously, like you have a huge air leak out of the drain, but it just might be something you need to consider. Or if that suddenly happens, so suddenly your ventilator starts alarming, leak, I've got an air leak, where's this leak going? And you get this big amount of bubbling in your chest drain, again, you need to let the medical officer know urgently about that, because your patient has developed or is developing a bronchopleural fistula. Chest auscultation, and we can have an argument about whether that's valid or not, but I guess not so much for noises, but we just want to know, is there air entry and is it equal, or is it not? And again, where physical assessment is great when we have a baseline and we're constantly going back to compare our new findings to. So you come on shift, you do a big physical assessment for this reason. What is my baseline? And so in 3 hours, when something's changed, I'm going to go and redo my physical assessment, and I'm going to take all these little pieces of the puzzle and pop it together and to let the medical officers know my concerns. We want to do a pain assessment. We want to be doing that reasonably frequently, because like I said, pain is probably one of the biggest issues that we come across in these patients. Baseline observations of the drainage system. So is there air, is there swing, and is there drainage? What's the quantity and what's the colour and consistency? And bowels, and this might sound funny, but particularly for our patients who are on pain relief, which most patients with a chest drain will be if they're receiving narcotics or codeine, we need to ensure that we are staying on top of their bowel motions, so that they don't get constipated and then end up with even more problems. All right, so let's talk about an air leak. So what is an air leak? So air leak is indicated by bubbling in the underwater seal drain. So where you've put the water in the water, you've got your 2 centimeters of water. As the patient breathes in, you get this bubbling. It's literally like you're blowing bubbles through a straw into a glass of water. That's what it looks like inside the chest drain. And that's the air escaping out of their lungs. So they've got their lung tissue, they've got a hole in their lung for whatever reason, and that air is going into the pleural cavity, and we've put a drain into the pleural cavity, so the air is coming down the drain and into the water. And the water seal is so that air doesn't get sucked back up into the patient, but air is indicated by bubbling. We document it as present or not present, and best practice and what we should be doing is saying, yes, it's here, and we should be quantifying that. And this is a graph, or a table, I should say, that I took directly from the ACI document. And that really uses plus signs as an indication of how much air leak there is. You can see they've tried to, again, give you some objective measures of whether it's 1 plus or 2 plus or 3 plus or 4 pluses. Some of the drains available on the market these days have an air leak meter. So on the drain itself, where the water sits and where the bubbling happens, you'll see, and I think I've got an image of it on the next slide, there's numbers, and the higher the number, the greater the air leak. So you could always document that number as well, because again, it gives you an objective measure of whether this air leak is getting better or whether it's getting worse. So that's an air leak. So the air is the air that's coming out of the lung through a hole into that pleural cavity and then being drained via the drain, via the catheter that we've inserted into the pleural cavity and down into the drain. And you can see this is the picture that I was just talking about here. So we've got an air leak meter on the drains that we have in our unit, and you can see a video would have been better. Video is always better to capture the bubbling. For those of you who've seen the bubbling, you can probably appreciate that, but this is not a bad picture. So again, if you imagine you've got a straw and you're blowing bubbles into a cup of water, that's exactly what an air leak looks like. So you can see here, we've got bubbles all the way across to, let's call this is level 6. So I would document yes, and then like 6. So that tells me how much I've got. Quite a large air leak. I've got a big air leak in this patient. And you can see here, this 2 centimetre line is the line of where the water in the drain needs to be kept at. And it's just saline or sterile water that's inserted. I can't remember off the top of my head, either or. So a sudden large volume of air leaks. So say you've been bubbling along at like 1 or 2, and then suddenly you've got a really big air leak. So either 7 or off the scale. That is a worrying sign and something you need to escalate to medical officers, because it can indicate that we are developing a bronchopleural fistula. If the air leak suddenly stops, so you've had air, you've had air bubbling along at 4 or 5 bars here, and then you go to check half an hour, an hour later, you're doing your observations and there's no air leak. That is a worrying sign as well. That would indicate that either our tube or our drain has been disconnected, occluded, kinked, clamped, dislodged. It's not sitting in the space. So you would not expect to go from a reasonable or a big air leak to nothing within an hour. So if you imagine, so I want you to try and picture that slide at the beginning where we had the collapsed lung. If we've now popped a drain in there and we're draining air, that lung is going to slowly re-expand. It's going to slowly get bigger and bigger and bigger. And that usually takes days. Like, it takes a few days for a lung to re-expand. Once that lung is expanded, you would expect to see those air bubbles stop. But that's a slow progression. So you'll start with a reasonably big air leak, and it will slowly get less and less and less and less and less over a period of a day or 2. And then when it's either very minimal or no bubbles would be when we try and take the drain out. So we'd take the drain out, and hopefully that whatever has caused the air to escape has healed over. So a hole in the lung or whatever has healed over. So slow cessation of air leak is normal. You may get post-op patients, so it might be post-op VATs or a resection or whatever, that come with a very minimal air leak or no air leak at all. And that's not uncommon. They haven't necessarily had a pneumothorax or a collapsed lung. What they've done is, because they've operated on that lung tissue and like popped holes in the lung tissue, they've put that chest drain in there prophylactically. So in some of our post-op patients, it might only be there for 12 or 24 hours before we remove it, but it's there just in case they do develop an air leak. We want to, I guess, in those types, that's a very specific cohort of patients. So oscillation or swing. So in our unit, we refer to it as air and swing, but you may have it as oscillation where you're working. It means the same thing. And essentially, oscillation refers to the changes in or it reflects the changes in intrathoracic pressure during breathing. So oscillation, we see this when we see the fluid so that 2 centimeters of water, we see the fluid. So you'll know there's the chamber there, and then beside it, there's like a long skinny viewing chamber of centimeters going up. So you'll see the fluid rising and falling and rising and falling and rising and falling in time with the patient's respiration. The other area that you see oscillation is in the actual drain tubing. you'll see if they've got some pleural fluid sitting there or some blood, you'll see the pleural fluid and blood oscillating or swinging in the tube, in the drainage tube, in time with the patient's respiration. That is normal. So most people will have some kind of oscillation, and yes, you can have swing but no air. So what that's telling me is that I don't have an air leak out of the lung, so I've got no air coming out of the lung, but my tube is responding, or the fluid in the chamber is responding to the changes in the pleural cavity as the pressure changes in the pleural cavity as the patient breathes in and out. We record oscillations as either being present or not present. Now, if oscillations aren't present, it basically means one of four things. It means that the patient is lying on the tube, or the tube is kinked or clamped. Again, there's those pressure changes in the lung are not being reflected further down the drain. So we've clamped or kinked the tube somehow. So step one, you need to inspect the drainage tubing. You need to inspect the catheter that's on the outside of the patient to ensure it's not kinked, clamped, or has been disconnected. You also need to look at it to see if there's any obvious blockage. So this is really relevant in patients who have a hemothorax or blood loss through their drain, because that blood may clot, and it can actually, I guess, it's occluding the drain. And if it's occluded, we need to clear that. Again, speak to your medical officers and escalate these concerns. I guess the final reason is that the lung has fully expanded. So when the lung has fully expanded, and all of these holes are kind of wedged up against visceral and parietal pleura, you stop getting sensing those pleural cavity pressure changes down the drain. So you'll stop seeing it then. So it can be a sign that the lung has fully reinflated. So in terms of observations, so we've got air, we've got swing, and the final thing we need to look at is drainage. Drainage, I guess the first thing is we're looking at an amount. So I've got two different, I guess, pictures here that show you different types of fluid in a drain. This drain here on the right is overfilled and needs to be changed, and that's certainly a nursing job in most sites. So again, refer to your local policy and procedure around how to change the chest drain when it's full. But you need some way of recording on your system your hourly output and your cumulative balance. So if this patient has had a chest drain, I come on shift and I've taken handover off this patient, or I got a written handover because the night shift did overtime and they've left an hour beforehand or whatever. And I come on and this patient's got a chest drain, and nowhere on the system, it's just got an hourly output of 10, 20, 30, 5, 10, whatever it is, but they've had this chest drain in for 7 days. I have no idea how much they've lost in the last hour, because I need somewhere a cumulative total that tells me what the drain was at an hour before. So basically I need to know that an hour ago this drain was at 700. So then I can say, okay, well, over the last hour, this patient has lost, 90 or 100 mils or so. So you need, whatever system it is that you're using, you need to document both an hourly output and then a cumulative balance somewhere. You'll find that most cumulative balances on systems reset automatically on a 24-hour period, usually midnight to midnight. So if you have a system that does that, you need to add a note or something that tells me what the total cumulative balance is. It's really good to document color. You can do this in your progress notes, or again, you might have a space where you actually do your ICC obs to document this. So whether it's blood stained, hemoserous, or whether it's straw colored, that is really useful information. Again, it's useful because we want to know about changes. So if you've had someone who's had a pleural effusion and we've been draining pleural looking fluids, or this kind of straw colored fluid, and then suddenly they start putting out blood, that is a concerning sign, and it's something we need to let the doctors know. And I guess also just to be mindful that large amounts are worrying, particularly in the event that it's a sudden increase. So if you've had a patient pottering along and they've been putting out 10 mils an hour, 5 mils an hour, 20 mils an hour, and suddenly they've put out 150 mils, that would be an immediate escalation to the medical team. Chances are we're going to sit on them and watch and make sure that it wasn't just a one-off hourly thing, that that's a consistent raising, but I can, that amount is going to continue to come out on an hourly basis, but we'd probably certainly be doing some initial investigations, things like hemoglobin, looking at the fluid status, have they had an increase in inotropes? Because we need to start investigating, has this patient started to bleed? Is something else going on? So very important that you, I guess, are mindful about how much is coming out. In terms of frequency of observations in an intensive care environment, I would say hourly to second hourly. So in our, I guess, our HGU patient population, or those who are cleared for the ward, we would expect observations done second hourly. In our patients who are, say, ventilated, sedated, or I guess on high level or inotropes, maybe on dialysis, we would expect those observations to be attended hourly. All right, a couple of absolute do nots, maybe not absolute, but just be very, very mindful. Please don't lift or hang the chest drain above the level of insertion. You can do this, but the drain needs to be clamped, and if you're not sure what you're doing, get someone who does know what they're doing, or speak to a medical officer. So you would never ever lift the chest drain above the level of insertion. And this is something that not became problematic, but I think you need to be really aware of in your patients who you might be proning. So in the event that you need to move a chest drain from one side to the other because you're flipping your patient over, obviously the location of drains is going to play a part in terms of deciding which way you're going to move them. But there may be genuine occasions that you do need to lift a chest drain up, but word of warning, it's a high risk activity and you need to be really mindful around what you're doing when you're doing that. We do not want to drain by gravity air or fluid back into that patient's pleural cavity, because even small amounts can cause a great deal of respiratory deterioration or hemodynamic deterioration. You do not want to clamp that chest drain without a medical order. So if you have someone who's cleared for the ward, ambulating around the unit, you want to take them for a shower, it would not be routine practice to clamp that chest drain. You may take it off suction for short periods of time. And again, a big proviso, this is all down to local policy and procedure. Most of our bathrooms are fitted with a services panel where you have suction, or you have a portable suction unit that you would take with you. But you would just hang the drain lower than the insertion site. So you would never clamp the drain to move them around. You only ever clamp on a medical order. And if you do have clamped a drain, or you do need to clamp a drain, you've clamped a drain because the output's too high and they want to stop the output, which would be one of the indications for clamping a drain, or you've had to lift the drain over the top of the patient, or you've had to change the drainage system, therefore you've had to put a clamp on the actual tube itself. Please ensure that clamp is taken off as soon as it can. I guess with the exception of high outputs, that needs to be very clearly outlined, documented by the medical officer when they want that drain unclamped. But in all other circumstances, the drain needs to be unclamped as soon as possible. And we're talking minutes, so you can't leave a drain clamped indefinitely or for long periods of time. That is how so again, talking about if you've got an active air leak, what's going to happen? You clamp that drain, that air can't get out. That air is going to build up in that pleural cavity again. It's going to squash the lung. You're going to get that respiratory deterioration and potentially hemodynamic compromise as the heart gets more and more squashed. So, yeah. Removing ICCs, pearls and pitfalls. So again, local policy and procedure, but you need a medical order to remove an ICC. You really don't want any bubbling. Oscillation is okay, so you can still have swinging or oscillation in the line, and it's safe to remove an ICC, but what you don't want to see is air bubbles, because that bubbling in the drain is indicative that we still have an air leak. Sutures, just be really mindful that you can get so some operators, when they're putting in chest drains, and depending on how they've inserted the chest drain and how easy or technically difficult it was, their own personal preference on insertion technique, etc. Most chest drains themselves will be actually sutured to the skin. So you can see here you've got an incision in the skin, you've got a chest drain coming out, they've wrapped a suture around and around and around the drain, and then they've anchored that to the skin. That is the one you need to cut to pull the drain out. You may, not always, but you may have a secondary suture that is actually to hold the skin closed. So remember when I said earlier in the talk that your incision site might be significantly bigger than the actual drain that's gone in? Well, what they want to do is they want to try and close all that extra space so that we're forcing all the air to go down the actual drainage tube and not track up into the subcutaneous tissue. So these extra sutures, please, when you're removing a drain, they usually don't get removed, and you need to clarify when you get it down and you've looked at the insertion site, if it's not already clear or you don't have a standing protocol for how this is done, you need to clarify exactly which sutures the surgeon / ICU team want removed, because these sutures that are just in the skin are often used to actually close the incision once the drain's been removed. So in terms of ongoing resources, always speak to your local education team. So it could be on a respiratory ward, in your intensive care department. They usually are, you know, a wealth of resources, and they've got a wealth of knowledge that you can tap into, particularly procedural stuff in terms of removing drains and nursing observations and nursing care of these things. If you're wanting some other places to look for some information, I found a couple of great anatomy and physiology videos on YouTube that were on the pleura and the different pleural conditions that you can get, and the insertion of chest drains. Deranged Physiology has a really good, I guess, page on chest drains. The ACI document is a fantastic resource, and the ACCCN textbook is very nursing relevant, and so well worth looking at if that is your field of specialty. So thank you for your time today. Thanks for your patience. I hope you've enjoyed this session, and I'll see you next time.